ready for
Very
Holly.
good. Okay, so I will turn it over to my colleague and friend, Holly Prince.
So bonjour, huichue queen additionakas thunderbina donjiba makwado dam. Introduce myself in my own language, which is a sacred protocol. And in doing so, I am honoring my Anishinaabe identity, my teachings, and my connections to all my relations. I am an Anishinaabe and member of Opawaganisining here in Northwestern Ontario, raised on the shores of Animagozagigan, which is Lake Nipigon. I come from the Makwado Dam, so the Bear Clan, who are the medicine people in Anishinaabe communities. I've lived in Thunder Bay now for over 20 years with my husband, who is Anishinaabe from Treaty 3 territory, along with my 3 children. My English name is Holly Prince, and I'm a social worker by background, currently doing my PhD in education. And for the past 17 years, I've worked at the Center for Education and Research on Aging and Health at Lakehead University, where I lead a program of research and education that focuses on improving care of Indigenous peoples as they prepare to journey to the spirit world. I would like to begin by paying my respects to the elders past, present, and future, for they hold the knowledge, teachings, traditions, and future hopes of my people. And I would like to start tonight by holding a moment of silence, honoring all the people who attended Indian residential school, the survivors and their families who carry the stories, knowledge, and ongoing trauma, the children who died and who never came home, and their families that continue to mourn them. Miigwech. In terms of disclosures, I am the project lead and contact expert for the livingmyculture.ca project for the Canadian Virtual Hospice. I'm also employed at Lakehead University at the Center for Education and Research on Aging and Health as a project manager. And I am a committee member for the Don Green Palliative Care Advocacy Team Advisory Committee for the Canadian Cancer Society. And I don't have any financial support for this. So I'm hoping by the end of the session, participants are going to be able to really look and discuss the historical and ongoing impacts of colonization and anti-Indigenous racism, particularly as they relate to healthcare, and look and describe at how equity informed approaches to care can create opportunities for culturally safer care. So this echo session is grounded in this concept of two-eyed seeing, and two-eyed seeing is a concept that was developed by Mi'kmaq elder Albert Marshall. And Elder Albert Marshall really defines this concept of two-eyed seeing as learning to see from your one eye with the best or the strengths in the Indigenous knowledges and ways of knowing, and learning to see from your other eye with the best or the strengths in mainstream Western or Eurocentric knowledges and ways of knowing. But most importantly, learning to see with both these eyes together for the benefit of all. So in 2010 to 2016, I was a part of a research team at Lakehead University, where we partnered with 4 First Nation communities in Manitoba and Ontario with the goal of improving the end-of-life care for these First Nations peoples by developing local palliative care programs and teams. And this project utilized the concept of two-eyed seeing in the development of these programs. And as you can see in the diagram, it was about taking the best of Canada's healthcare system capacity, combining it with what was the capacities in First Nation communities to really develop local capacity development strategies and to develop and build upon these local palliative care programs and teams. So this ECHO series outlines the significant contribution that this concept of two-eyed seeing can have to the end-of-life care of Indigenous peoples by intersecting both Indigenous knowledges with that of the Western palliative care philosophy. So the Truth and Reconciliation Commission of 2015 states that without truth, justice, and healing, there can be no genuine reconciliation. The problem with this statement is that there's too many Canadians who know nothing or very little about the ongoing role and impacts of colonization. So there is no truth. So now throughout this session, we're going to start unpacking some of these truths today, discussing how Canada came to be and about the ongoing impact of colonization experienced by Indigenous peoples. So colonization affects us all. It's not just something that happened to Indigenous peoples as the colonized. It involves a nation of people as the colonizers. And whether people's families settled here in Canada generations ago or just recently, colonial policies and rules and structures and systems continue to exist today, which in present day negatively impacts Indigenous peoples and continues to benefit settler Canadians. In Canada, there is no greater institution, policy, structure, or public face of structural racism than colonization. Colonization was based on racism, the belief that one group was superior to another group. Colonization defined whose knowledge was valued and privileged. Colonization forced policies and legislation onto Indigenous peoples to assimilate them into Euro-Canadian culture through the Indian Act. And through the Indian Act, we've seen the residential school system, the reserve system, and the enfranchisement policy, just to name a few. So in addition to these, though, the Westernized Eurocentric healthcare system was also driven by colonization. So the planning, design, and imposition of Westernized medicine on Indigenous peoples was really about invalidating Indigenous knowledges, healers, practices, our medicines, our caregiving models. And what it did was it really fostered this deeply internalized oppression and replaced our traditional healing with biomedicine. Indigenous peoples were also treated as objects of the healthcare system for the purposes of research and experimentation. So residential schools were the sites of scientific research experiments throughout the 20th century, including studies of students being intentionally starved and malnourished, as well as the testing of TB immunization on children in Indian residential schools. So Indigenous children who were part of this human experiment work were the direct wards of the government. Therefore, they couldn't voluntarily consent to participate. There was also a segregated health system for Indigenous peoples, which included segregated hospitals, so the Indian hospitals, and these hospitals were severely underfunded with low standards of care. And in some centers, the actual local doctor was also the Indian agent. So these hospitals were developed really to lessen the white settlers' fears associated with the communicability of tuberculosis. The Indian Act was also amended in 1953 to include the Indian health regulations that made it a crime for Indigenous peoples to refuse to see a doctor, to refuse to go to the hospital, and to leave the hospital before being discharged. And the RCMP actually was able to arrest patients and return them to hospitals or send them to jail. So when we're looking at health disparities and barriers to care within Indigenous peoples, that lack of access to equitable and culturally safe healthcare is embedded in colonization and jurisdictional issues. So there really is a lack of ownership and accountability in determining which level of government, so the federal versus the provincial or territorial, is responsible for delivering healthcare to Indigenous peoples. And in addition, responses to addressing the needs are really evident between the three distinct groups of Indigenous peoples, so First Nation, Inuit, and Métis. So we have this jurisdictional gray area whereby each level of government considers themselves at times the payers of last resort. And that's really evident when you're looking at the development of Jordan's principle. So this jurisdictional gray area is really a barrier to provision of health services, including home-based palliative care. We also know that the provincial health system lacks understanding of the federally funded health system's policies and procedures when it comes to non-insured health benefits, for example. So these transition points between these two systems of care really highlight the lack of coordinated and integrated care, as we see, which is evident through inadequate hospital discharge planning. We also see an inequity of resources, access to medication, equipment, and health human resources in First Nations communities. So in a recent report in Plain Sight, it really highlighted the magnitude of racism within the healthcare system. And what it did was it identified 5 primary findings. So that there was widespread Indigenous specific stereotyping, racism, and discrimination that existed within the BC healthcare system. That racism limits access to medical treatment and negatively affects the health and wellness of Indigenous peoples. That Indigenous women and girls are disproportionately impacted by Indigenous specific racism. That current public health emergencies like COVID really magnifies racism and vulnerabilities for Indigenous peoples. And that Indigenous healthcare workers who work within this system also face racism and discrimination in their work environments. So in this review that was conducted in BC, 84 of the participants who were involved in this reported discrimination. And within that, 13% of the healthcare workers who were responding to this actually made racist comments when responding to the survey. So that's how ingrained racism within the healthcare system is. And before we breathe a sigh of relief saying, oh, that just happened in BC, we need to acknowledge that racism in the healthcare, when it comes to Indigenous peoples, is nationwide. And Joyce Echequan and Brian Sinclair's deaths are testaments to that racism within the healthcare system. So what do we know? So we know that Indigenous peoples are currently ranked lower in almost every social determinant of health as compared to their non-Indigenous counterparts across the world. Indigenous peoples are the world's most marginalized populations, and they suffer from really high rates of chronic illness and lower life expectancy compared to their non-Indigenous counterparts. We also know that when people are diagnosed with life-limiting and terminal illnesses, they, along with their family, would benefit from support and care. However, Indigenous peoples' health care, particularly on reserve for First Nations people, is not funded at the same level as non-Indigenous counterparts, and they really lack access to palliative care services. So due to this inequitable access to health care, Indigenous peoples must access healthcare outside of their communities. But if we think back to the previous slides, we know that the healthcare system was built on colonial underpinnings. So as they enter the healthcare system, we witness stereotypes where they're less worthy, they're alcoholics, they're drug seeking, which leads to discrimination around denial of service, inappropriate pain management, which negatively affects their access to care, so mistrust or avoidance of the healthcare system. This in turn negatively affects their health outcomes, so the reduced life expectancy, higher rates of chronic illness. And these factors contribute to reducing the quality of life for Indigenous peoples and the overall burden of disease to be addressed during end of life. So it becomes a vicious cycle. So to break this cycle, we need to look towards equity-oriented approaches to caregiving. And the first thing we're going to explore is this concept of cultural safety. And this was something that was defined in this particular by the First Nations Health Authority. And what cultural safety is, it really is about seeking to achieve better care through being aware of difference and decolonizing and considering power relationships, and about implementing reflective practice, and by allowing the patient to determine whether or not an encounter is safe. So cultural safety only occurs when Indigenous peoples tell you that they feel safe. So it's not up to the Indigenous person or family to advocate or to teach or to direct the organization. They can participate in discussions, but it's really our role as healthcare providers to ensure that we are delivering patient-centered, safe care. And it's the organization's responsibility to ensure that they're creating safe spaces. The next thing we're going to look at is around cultural humility. And cultural humility is that process of critical self-reflection. It looks into our values, beliefs, biases, assumptions as healthcare providers. And it also helps to focus on those institutional biases with the goal of addressing privilege within relationships. So cultural safety requires healthcare providers to exercise cultural humility. So cultural humility, this is what contributes to that safer system. So it is about analyzing power imbalances and discrimination and colonization as they apply to healthcare. So while in most times in Westernized medicine, our focus is on the client, what cultural humility really is about looking internally at ourselves, really reflecting and doing a deep dive into our values, our beliefs, our biases, our assumptions. And it also seeks to address that privilege within the relationship. So it creates space for Indigenous voices to be at the center. It promotes patient-provider relationships, really based on things like mutual respect. And cultural humility is also really relevant when we're talking about trauma-informed, human rights-based approaches. So when we're thinking about trauma-informed care, this is something that we hear a lot about now within the healthcare system, within literature. And when we're thinking about how does trauma impact palliative care access, well, we think about trauma. Trauma is that collective experience shared by many Indigenous peoples in response to colonization. And when we think about how trauma impacts palliative care access, we need to recognize that colonization created systems and policies that were founded on racism, which are still evident today. And this is the system of care that we as Indigenous peoples are expected to live within. So trauma-informed care is about shifting that individual and organizational and system level focus and changing the narrative from what's wrong with you to what happened to you. It's about understanding that historical picture of someone's life and really looking at the impact of the historical and current trauma to provide safer services. And trauma-informed care is about actively avoiding re-traumatization. So when we're thinking about how do we create these safer spaces and how do we create safer care, Indigenous peoples really need to be leading the way in developing and reactivating caring for our own people. And Indigenous concepts of health and well-being must be accepted with support given to Indigenous health systems and services. And things like structural systems and policies that have been imposed through colonization need to be challenged, and they need to be challenged by everyone here, both as individuals and organizational levels. And lastly, healthcare systems and providers need to challenge their own power structures and their own cultural identities in engaging in safer relationships and in more mutual and beneficial relationships with Indigenous peoples. So with that, I'd like to say miigwech, and I think I hit my time right on time.
You did indeed. Well done, Holly. Thank you. I know this is such a difficult body of information to try and bring together in a very short space of time, but thanks for setting the stage, I think, with the important pieces, and I'm sure that some of these pieces will probably find their way into our conversation, I'm sure.